Good morning. Morning. There you
Morning,
go.
can you hear me?
Yeah, you hear me?
Yeah.
Okay. Let me share my screen.
Okay.
We'll get going here. Okay. Can you see it?
Yeah.
Okay. Great.
Good morning, everybody. Welcome to our second installment of our pediatric dysphagia series. Thank you to all who are able to join, and thank you to Dr. Thiru for helping put this together. Today we have Lauren Schrank and Natalie Kovtun, two of our speech language pathologists who have expertise in feeding, who will be talking about toddler and young adult feeding and swallowing, evaluation and treatment.
Cool.
Great. Well, thank you all for joining us. Lorna and I are excited to talk to you today about feeding and swallowing, like Dr. Rowell was saying, and evaluations in toddlers through the young adult population. Some of the information today may seem a little bit redundant to start, but you'll see that as we go on, there will be notable differences as we are focusing on those older kiddos today. So to start, let's begin by going over some basic definitions. Feeding refers to the development of eating and drinking skills. It is a global term encompassing the entire process of eating. So this includes all aspects of eating or drinking, including gathering and preparing food and liquid for intake, sucking or chewing, and swallowing. It's also achieved through tube feeding, as we know, with our G-tube and NG-tube fed kiddos. So swallowing then refers to a complex process during which saliva, liquids, and foods are transported from the mouth into the stomach while simultaneously keeping the airway protected. So this is all very oversimplified, and we're going to go into detail. So feeding disorders, next slide, please, Lauren.
Yep. Sorry, give me a second.
It's okay.
Let me go back.
Go back one.
No.
There we go. So feeding disorders occur when someone has problems getting food or liquids into their mouth and or chewing. It may or may not include problems with swallowing, okay? So a pediatric feeding disorder, or PFD, is any difficulty a child has with oral intake as compared to their same age peers. So we're going to be talking about and focusing on the four domains associated with this. And it could be medical, nutritional, their feeding skills, and or psychosocial dysfunction. We consider a pediatric feeding disorder acute if it's been present for less than 3 months, and chronic in nature if it's been present for greater than 3 months in our patients. Next. Okay, so like I was just referring to, there are four domains that underlie PFD, okay? So, and because of this interplay between these domains, one can lead to dysfunction in another. So again, the medical is the body's physical ability to digest food. Nutrition or nutritional is the willingness to eat a variety of foods with high nutritional value. This basically really focusing on, is the child able to meet their nutritional needs? And then feeding skill, the actual feeding skills that are involved, such as chewing and swallowing and managing the sensory aspects of eating. And the psychosocial part is the learned ability to eat without distress, okay? So because of this interplay, though, if a child has a medical condition that limits their feeding experiences, they'll likely not be able to develop the feeding skills necessary to be able to consume these foods like their same age peers. So typically, this is then where you run into, if their intake is limited, that's going to be affecting the ability that, them meeting their nutritional needs. And then oftentimes these families, then you'll see the psychosocial component where they start to have really stressful feeding times, really stressful and just negative experiences during these meal times for kids. So think about what that may do for them going forward. Common disorders of feeding would be difficulty transitioning to age-appropriate textures or foods, gagging on textures, refusal of these textures, very limited repertoire of accepted foods. So that may be, we have a lot of patients who come in and families sharing, my kid only has, their favorite things, goldfish or snack foods, or only certain colors of foods, whatever it may be. It's 2 or 3 things these kids are eating. And if you imagine, this is going to make it very difficult for them to meet their nutritional needs. They have a difficulty transitioning to the cup or to more age-appropriate drinking vessels after having or being on the bottle. Chewing difficulty and prolonged feeding times. Lauren will go into this a little bit later, but we noticed that they're not as efficient as maybe they should be. Okay, and then overall feeding refusal. So ARFID, avoidant restrictive food intake disorder, was first recognized. Okay, so before I go into it, let's talk about, well, we just talked about pediatric feeding disorder. We're going to kind of shift gears to ARFID because it's important for you to realize that there's a difference between the two and how one can kind of turn into another. Okay, so ARFID was first recognized in 2013. It was an expansion of the mental health diagnosis feeding disorder of infancy and early childhood, found in the DSM-4. It can occur across the lifespan, and it's a feeding and eating disorder and mental health diagnosis that describes children and adults with feeding problems and related nutritional risk without the medical issues or body image concerns, okay? So a lot of times we have kiddos that come in and, we get referrals and doctors may say, or parents may say, these kids are just really picky. They're very selective, but understanding why and that it is an actual diagnosis. It's more complicated than what it may seem. Okay, so kind of quickly here, the primary feature of ARFID is food avoidance or restriction motivated by sensitivity to sensory characteristics of food. So fear of aversive consequences of eating or a lack of interest in eating altogether. There are 3 main types of ARFID. Selective eating, we kind of talked on that already. So these kids are more sensitive to taste and texture of food. They might not seem, they may not eat certain food groups or want to try them, and their diets are limited. There's a lack of interest in eating in some of these kids. So they have little interest, they don't feel hungry, may get full fast, or complain of stomach aches, nausea, cramping, or other GI symptoms. The third type would be fear of eating altogether. So these kids are just scared. They're scared of choking, getting sick, or vomiting. They may take little bites, but generally, these kids are only having small amounts again, okay? So a child may have behaviors that fit one or more of the types of ARFID. And then something to consider too is that the weight loss or failure to meet growth expectations, nutritional deficiencies, dependence on enteral feeding, interference with psychosocial functioning. So these must be present with the impairment in one or more of the following, which I just went through, okay? SLPs do not diagnose or treat ARFID. It is a mental health disorder, okay? So in these cases, we need a psychologist as well as a multidisciplinary team to make the diagnosis and treat appropriately. Okay, so shifting gears now to swallowing disorders, dysphagia. A swallowing disorder involves difficulty processing and or moving liquid and or food boluses through the oral cavity, the pharynx, esophagus, or the gastroesophageal junction. It can occur in one or more of the 4 phases of the swallow and can lead to aspiration. So this image here gives you a good idea, with the green being the bolus, of the different phases of the swallow that we've just talked about. Next. Okay, so oral pharyngeal dysphagia is difficulty moving food and liquid from the oral cavity to the pharynx and into the upper esophagus. And the esophageal dysphagia would be difficulty moving food or liquid from the esophagus into the stomach. And it's important to note that as SLPs, we don't manage the esophageal dysphagia, but we make appropriate referrals for its diagnosis. So these kiddos would be sent off to GI, but again, we see the whole child, and so we're diagnosing the oral and pharyngeal phase and really, sending these kiddos off to GI if needed. So today we're going to be focusing on toddlers through adolescence. I thought it would be nice to just have this idea of what that means, because when you hear the word toddler, you don't know, is it 2, is it 3? So it's anything really 12 months to 5, early childhood being 3 to 8 years old, middle childhood being 9 to 11, and adolescence 12 to 18. In terms of the specifics of each of these kind of age groups, you're going to see that, for certain skills, it's all just going to be refined as the kids get older. So mostly just focusing on, we're getting off the bottle, we're working on solids, refining skills in the oral and pharyngeal phases for all. Okay, and then again, another way of depicting the differences as our patients get older, and you're seeing the oral and pharyngeal just represented here. And so the intraoral space of the newborn is smaller, as you can see. The lower jaw is slightly retracted. The tongue takes up more space in the mouth. The epiglottis and soft palate are closer together in the infant, and this serves as a protective mechanism. And then the larynx is in the neck of the newborn is higher than in the toddler and older child. Another thing that we see a lot in our swallow studies is that the hyoid looks a lot darker in our older kids because it's bone and not cartilage any longer.
Okay. All right. So, as Natalie was saying, we're really going to focus on kind of the 12+ month olds today, and we did go over this a little bit last time, but I just wanted to start here. And if you want to take a picture of this or just have this is just kind of the typical normal feeding milestones for our kind of infants who are transitioning. But something I was kind of thinking about from our conversation last time was, you see a lot of children, right, who are exposed to that open cup drinking sooner. So their milestones might look a little different. And I was curious if there was any research or anything that's been done to look at the progression of the children you work with and see how that might be different from our feeding milestones here that are those more westernized kind of feeding milestones. So if anyone has any info, you can always put that in the chat. I think that'd be interesting. And I also think because you're starting cup drinking sooner, and that is a more mature oral motor pattern that requires them to have some more mature patterns, that might just impact the total progression of their oral motor skills with feeding as they start learning other things. So these are just questions I've kind of thought about. And so if anyone has any articles or any research of, just let us know. So I'll kind of start though with the 11 to 12 months here, and we'll kind of just go through some of these patterns. We were talking about now how tongue tip elevation emerges. There's intermittent tongue protrusion noted when swallowing foods, but it's not nearly as much as it is with like those 5 to 6 month olds or the 7 to 8 month olds. You're starting to see diagonal rotary chewing patterns emerge. And I'm going to get into chewing more specifically and kind of generally as we move along here. And then the biggest difference here, I think, is food is easily transferred from the center of the mouth by the tongue to the side. So center to side, not necessarily full bolus shifting to both sides of the mouth, but that's starting to happen. Okay, so again, I just wanted, before we really get into the specifics of chewing, just to give you general chewing guidelines so you can kind of keep these in your head. And just remembering these are very general. So really, I think when chewing is discussed, a lot of parents say, oh, they don't have teeth, or oh, they're getting their teeth. And teeth are important, but really the tongue is so important in chewing. And I think that's really where it starts. So tongue control is crucial. And then also just the tone and strength of those other oral structures, right? The lips, the cheek, the jaw, that stability, that the jaw is really the stability of everything. So we're going to focus on building those intrinsic muscle control. So again, more stable jaw movements, more up down movements, and then those are going to transition to more lateral movements, the jaw moving as they're progressing through these phases of chewing. And then really looking at the overall tone and postural stability, head trunk control of that child. That's going to be really important. Um, so knowing where they are developmentally as well will affect chewing and their positioning when they're eating and things like that. So again, we'll go through this just generally. They really start with that munching, or I kind of call it interior munching, or I call it the squish and squash, where that's how I say to parents, they're just kind of squishing and squashing, and you don't really see um, any lateral movement of the jaw or anything like that yet. And they're really, really small range of those jaw excursions. Then you'll start to see more of the up down vertical chewing and kind of light contact of the actual gums, just kind of like up down. And you'll start to see the tongue is still pretty disorganized. I shouldn't say that. They're still learning. So you'll just see these bigger rolling movements of the tongue. And then they will progress to more of this diagonal shift of the jaw in conjunction with better, more coordinated lateral actual movements of the tongue, a little bit not as rolling and big movements, but lateral. And then you'll see more, they'll really progress to a more circulatory rotary chewing motion. And that's really where the jaw is moving in that circular motion. And you'll start to see that start to emerge with a lot of kids around 2. Again, we're going to get into this more. And it can take to 3, but even 4 years of age. So we'll get into more specifics, but just remember anterior munching, vertical chewing motions. Then you start to see diagonal shift of the jaw, and then more of that circular rotary chewing. Okay, so here's where we'll kind of break it down a little bit more specifically based on the child's age. And I just want to say this with the caveat, this is based on a neurotypical child. We see so many kids who are not neurotypical or who have, just really significant medical history. So they're going to move through these phases differently. So again, like weaning from the bottle, we'll start to see. But for some of our kids who are not neurotypical, have reduced head trunk control, the bottle is actually appropriate, or breastfeeding or whatever they were doing, or using that cup, that can still be very appropriate just so they're safe and, efficient. I think that's the most important thing. But for our more typical developing kids, we're weaning from the bottle. You can transition to a sippy cup depending on who you talk to. You'll probably hear different things. I will put that out there. I'm okay with it again if it creates more independence for that child. They can hold the cup. It's more of a short-term thing for me when I'm moving through this with children. And then sometimes I just skip it all together and I will go more to the open cup or the straw. We tend to use more smaller cups at first, or the nosy cup. It's like the cup with the little cutout, so they don't have to worry about their nose hitting the edge of the cup. And we also use a lot squeeze straw bottles, so you can compress the bottle actually, and some of the liquid comes out of the straw just to teach them initially that, hey, liquid comes from here. You just want to be careful. It's not like a syringe where you're kind of like just pouring liquid into their mouth. You want to be very purposeful and make sure they have that good lip closure and they're active in that straw drinking. But they're still going to need support during this phase, right? Then as they get more to 18 months, you're going to start to see, okay, they don't need my support. They have less spillage. We're really refining the coordination in these skills versus really having to start from the ground up. And then food wise, we're moving into, again, I would say more at that 18 months, not really 12, but more of the soft, easy to chew, still mashed foods even at times. I think it's a combination of foods with these kids, textures and things. But that would be like an IDSI level 7, easy to chew. Again, we're avoiding those tough meats, those circular fruits like grapes and then like nuts, things like that. We're cutting these pieces up, and there's still that preference for those softer foods. They're starting to self-feed using their fingers and utensils. And then again, kind of like I said before, we're just really starting to refine some of these chewing motions more. Okay, 18 to 24 months. So really now they're sitting without support, right? They're feeding themselves a lot, especially around the 24-month-olds. Feeding themselves with their fingers and utensils still, but and I think that's going to be different based on like the finger feeding versus the utensils based on where you are and culturally and things like that. You'll just see improved lip closure around the straw and cup, and even just improved lip closure during the swallow. You'll start to see more precise up down kind of like tongue movements, lateral tongue movements. And I think the big difference here too is controlled sustained bites. They're opening their mouth wider. They're to really kind of like bite these thicker consistencies or solids. And then they're moving more into, again, more around that 24 months, the rotary circular chewing motions. And they're starting to become more efficient chewers because of that pattern, and they're chewing foods more on the side of their mouth. And really you'll see consistent tongue lateralization because again, that tongue is the most, I think it's just so crucial. It's the beginning step of chewing, getting and moving the bolus and controlling the bolus and moving it to the side, being able to chew, and then slightly lifting it off those back molar table areas. Doesn't have to come fully center, but slightly lifting and then swallowing. And then again, foods that require a lot of chewing, like chicken breast, if they're eating meats or things like that, we're still cutting into smaller pieces to prevent choking. And then here we go, 24 to 36, so around 3 years old now. Now they're really using that, their forks, their spoons, everything nicely. You can still use your fingers though. They're drinking from the open cup without spillage, like that significant anterior spillage, and you just see generally better coordination, right, from when that liquid enters their mouth. And they swallow. Those circulatory rotary jaw movements, like we were talking about, now you're seeing the actual jaw moving that way. By 3 is looking pretty good. Again, though, I think the chewing and grinding movements, some of our kids really, and this was actually taken from the Arvidsson Elliott Clausen article. It can take till 4. So I say that with kind of like some, and again, I think it's a continuum. It's not the same for every child based on where they are in their development. But I would say at 3 still, sometimes like we need to cut those foods. Those tougher textures can be still hard for them because they're still refining those circulatory rotary chewing motions. And then really they're eating a variety of table foods. So by 3 here, they're looking pretty good. Okay. All right. So now we just went through some of those feeding milestones. I'm just checking my time. Sorry to see how long I've been talking for. So now let's move into the actual clinical evaluation. So when they come in, you see them. So now we're going to talk about that. And I think this slide was really meant, so we have feeding disorder, swallowing disorder, both. Is there an ARFID component? Or if you're kind of screening for that in your mind, because as SLPs, we can screen for ARFID, and we have a role in that in identifying those children, which I think our role is actually really important because we are often the first ones to see those kids. But really doing a thorough chart review, case history, getting all the information you can on that child. So for example, like I'm thinking of a kid I saw the other day, prolonged intubation, was in the NICU for 4 to 5 months. And I just thought off the bat, developmentally, this environment was not a typical environment for this child. They probably did not have typical feeding, experiences. They were having issues drinking from the bottle because of their poor respiratory status. They couldn't even eat from the bottle for the first, I think it was a couple months or whatever it was. So again, just kind of looking at their history, looking at their medical comorbidities, understanding how those medical comorbidities are going to affect that child, how those medical comorbidities affect each other, and then how they're going to affect feeding and swallowing and just their feeding and really early feeding experiences as well. So really looking at all that, and then I kind of have a little bit of a hypothesis, going into the room. But again, I don't want to make a full one because every child's different. They surprise me all the time. And I think though there are just some things you can kind of just have a little bit of, okay, I would expect this. Maybe they have difficulty here, but just kind of having that in the back of your mind, I think is very helpful. And because we know the medical comorbidities and understanding those are really crucial to your evaluation and understanding where this child has been and where they're going to go. So again, these are things I would consider in my chart review, but also like during the evaluation and kind of dive into more with the parents when collecting the history. So we have any pulmonary concerns, right? Like, did they need supplemental oxygen? Like, I want to look at that. Was there any intubation? Did they have like recurrent? And this is kind of, I know that was a little bit the history part when they were younger. So fast forward now to when they're a little older. Do they have like frequent upper respiratory infections? Any pneumonias, right? Persistent coughing, like a baseline cough. Parents will say, hey, they just kind of cough all the time. And then you want to tease through that. Okay, are they coughing all the time? Is it also when they're drinking liquids or eating? So really asking those specific questions. How does do they have a wet or gurgly kind of like vocal quality? And you can have just like a wetness at baseline, you can, or does it get worse as they eat and drink? And just looking at like, do they still continue to need supplemental oxygen? We have children, on nasal cannula, trach vent, all that type of stuff. And then this is a huge one, I think, gastrointestinal issues. Do they have poor growth, failure to thrive? We're kind of transitioning more to malnutrition as a diagnosis there, but what is their weight and their weight for their height, which is really important too. Are they having recurrent vomiting? Do they have specific food limitations and food refusal? So also I think about my kids who have a supplemental or alternative means of hydration nutrition. So the G tube fed kids, the NG tube kids, what's the rate? How much are they getting? This will really, I want to look at their hunger cues. Are they set up from a medical standpoint and medically managed to get hungry and have that intrinsic drive to eat, which is so important because you can do therapy, and things, and we'll get into that. But if they are not medically managed, it's a real disadvantage for the child and you as a therapist. But you can also kind of do more, I think, more damage by if we're trying to feed them and we're, doing all these things and they're like, wait, my body's not even ready to really be eating yet. So really looking at them from that medical management is just really crucial. And then structural defects, right? Cleft palate, laryngeal clefts. We have our tracheoesophageal fistulas that could kind of go up in gastro too. So just things like that, which I feel like those are identified pretty early. Other things are neurogenic causes. We have a lot of kids with HIEs, stroke, IVHs, just infections, a traumatic brain injury, things like that. A lot of we have little ones we see in car accidents, things like that. Genetic syndromes, and Kathy is actually going to get into this like a lot more in depth I think I don't exactly know which talk, but her genetics talk. So she will get into more of these genetic syndromes and feeding and swallowing, but I just have some listed here. And then a big one again is cardiac diagnoses and their surgical histories. I mean, surgical history generally, right? Or if there was anything new, but also specifically cardiac surgical histories, because that'll tell you a lot about just how their heart was working, right? And functioning. And we know that's going to affect eating, and especially as babies when they're really dependent on just liquids. But also too, because it kind of goes into my next point, upper and lower airway diagnoses. Is there a vocal fold immobility issue, right? Because with those cardiac procedures, especially if you're going like a PDA ligation or anything around the aortic arch, where that recurrent laryngeal nerve runs, that actually is responsible for that vocal fold movement. You want to really be aware of those things. And then again, that's moving into upper and lower airway diagnoses. So laryngomalacia, we have our, um, anything else, vocal fold immobility, all that good stuff. And then lower airway, but obviously lower in the airway, trachea, and just pulmonary things. Okay. Okay, just want to make sure I didn't miss that. Okay, so this is kind of more of, okay, you're in the room now with the parent, and I know there's a lot on this slide, but I just wanted to put it on there. So if you want to take a picture or something, it's all in one place. But I think really, again, talking about their history, talking about their birth history, their medical history, mom's birth history, right? I mean, with the baby and everything, any medical diagnoses, and then really start getting into, why are you here? What are you thinking the issues are? Because I want to hear from the parents' perspective. Obviously, I think that's really important. And then the child will show you as you do the evaluation what the issues are, right? So, oh, I think someone's writing on the slide. But okay. So also too, I really, during these evaluations, make it a point to go over how complex feeding and swallowing is, and really have, I kind of think of it as the big circles feeding, swallowing's kind of another little circle in it. And then from everything branching out, you've all their body systems that affect feeding and swallowing. So whether it's GI, respiratory, cardiac, they're just overall tone development, GI, all these things, early feeding experiences. And all it takes is a hit to one of those little things. It's almost like a little web that you draw for them, an organized web. And that's all it takes is for one hit to one of those systems to make feeding and swallowing really hard. And this is why, and let's look at your child specifically and look at which systems have been affected. And I found that is so helpful, especially when you're figuring out what type of learner you have with the parent too, how they learn. But having that visual and showing them really just, I think, sets the stage for this is complex. It's not as easy as just putting the food in their mouth and saying, eat, I wish it was. But this is, and I always say too, this is one, swallowing and feeding is just extremely complex. And I feel like I've said that 3 times, but it just is. So also you're going to look at, I kind of do a little screen, just their overall development, right? Gross motor. I'm not a physical therapist, but, and it's helpful to reach out to them and say, hey, what should I be looking for at certain ages? And even if you have a little screener, I've done that before, which has been really helpful. But looking at their head trunk control, are they like crossing midline yet? Are they switching toys in between their hands? This is all important for chewing and all these, because all these bigger gross motor movements are going to occur before these fine motor movements of the tongue and things are. So really, and if you, if you think, I'm not too sure, I feel like this child, maybe, something's not, their gross motor isn't exactly where it needs to be, referring onwards, but we'll get into that. And then obviously, an assessment of their oral structures. Sometimes it's going to be hard, especially with your like 12-month-old, or 2-year-old, 3-year-olds who are like, no way. But, kind of make it a game, especially for like your oral mech exam. I make it fun, do a Simon Says, most of the time you stick your tongue out at them, they'll want to do it back to you and just kind of show them what you want them to do. And most of them will do it. Most of them will. And I kind of already talked about this in the beginning. We were getting their feeding and swallowing history. The history is really important. I think you've got to know that to really understand then where this child is going. And then you can really get into, okay, what is your current feeding regimen? What is the schedule? When they get up, what is the first thing you do? Where do you seat them? Who is feeding them? I really want to hear from the parents, like how they present the food, right? Like all these things. And I take a food inventory essentially to know specific types of foods. what liquids they're drinking, what's the volume of those liquids, how are you presenting those? Are you doing solids first, then liquid? Are you doing them both together? All those things. And I really want to, during the evaluation, to talk to parents about, like, what do you think is going well when you're during your meal times? What do you think what stresses you out, kind of, and just asking them, or how do you see your child struggling, and getting their perspective, right? And a lot of the time, I don't feel like that just comes out naturally as you're talking with them. But again, some other things, I'm going to go back a little bit. I did say food quantity, frequency, what foods are they offering? What foods have they tried? How many times? What behaviors is your child showing you that they don't want to eat or don't want to drink that liquid? Specific behaviors, how frequently are those happening? Are you using utensils, and what drinking vessels too? That was another thing. Okay, let me jump back to stress and disengagement behavior. So again, we kind of already talked about this, and that can be for the child and the parent really too. I think you've got to get a really good handle on too the parents' behaviors and the parents' actions as well, and understanding their whole dynamic during their feedings, because that is really crucial as well. And then obviously, like, I kind of step back and I want to watch what the parent does. So I step back and I want to see, they usually have the food, or if they don't have everything, we have some food options for them too. Um, and I just watch. I want to see how they're presenting everything to that child. And we'll use their drinking vessels they're using, usually start with maybe more of a mashed food, go to, or really wherever they are, right? Whatever foods they're taking, and look at their chewing skills, looking at their cup drinking, straw drinking, just looking at all those skills, and kind of going back to those typical feeding milestones, like things like that, like looking at those things. And we're going to get way more into the assessment. But I just kind of wanted to tell you that's kind of what we would do. Okay. And really during the assessment too, looking at their positioning, because positioning is everything. That's what I always say. Positioning is everything. It is really the base of everything you're about to do. The positioning has to be good, so everything else can build on top of it, and they are secure from a postural tone standpoint. So really, when this is a picture of more, again, this is a neurotypical child. I rarely see children that don't have some gross motor or delays, or that are neurotypical. So you can see, like, in this first picture here, more on the left, like, he has no, I don't even think there's any straps or anything. Like, he's got pretty, and he doesn't need any postural support, and he's older. But you can see, like, his hips are at a 90-degree. Then you see his legs. You just kind of follow the arrows there, and there's that 90-degree with from his knee to his ankle, and then also his feet there. So it's a 90, 90, 90. He is really nice and supported, I will say, from his feet and up. And then we have this little one here on the right, and I don't even think he's got any, like, straps on, or just for that more trunk control. A lot of our kids need straps, or a lot of our kids need roll towels, kind of in between their hips and the chair, if there's space there to give them that stability from their hips. But I will say, this is a great chair. If you look, his feet are supported, that 90-degree angle. He's got that tray in front of him, right? And I always think about, like, if you're an adult and you're sitting on a stool and your feet aren't supported, like, I just even feel, and my feet are dangling kind of from like a stool or something, I feel much less supported. So I can't imagine a child who is still working on, like, their, development. And if they're so focused on that and they're not stable from their postural standpoint, chewing and these other skills are going to be really hard for them. I always say, it's like, you think of it as like you need a good foundation for your house, and then you can build your house on top of it. You've got to have that good postural stability for everything else to build. So I will fix that pretty quickly in my evaluation if I see a child is not supported. I don't let them just go through the whole evaluation. Just, I fix that pretty quickly. And we have, but it's hard because sometimes you don't have access to really adaptive and supportive high chairs, right? And seats and things. So I will even sit on the ground on a little mat, and I'll have the parent hold them in their lap and support their head and their trunk and their things like that. So just any way you don't, the chairs and things are nice, but that is not always reality, I feel like. So you've got to just kind of figure out, how do I make this child feel more stable? Um, so really important. I'm sorry, I feel like I was on my soapbox with, but I feel very passionate about that. Okay, and this is my little friend. I just wanted to show this picture. Yeah, I don't know where that line's coming from, that yellow line. I don't know, but that's okay.
It's on every slide, yeah.
Yeah, I don't know where that's coming from, I think, but that's all right. Um, he is not neurotypically, he's not a neurotypical child. He has cerebral palsy. He had some pretty significant um just neurological history. But you can see here, like, this is a really nice chair. He's got his feet really supported. Again, I mean, he's got all the postural supports, even in his neck and his head. And but it's amazing after he got this chair. We used to put him in a tumble form chair. Once he got this chair, though, like, how much more engaged he was during the sessions, and just how much more he could do, because he felt he was just more supported, again, from his foundation, right? His postural stability. And look how comfortable he looks. I don't know. I'm just like, he's ready. Like, you can just see it when their positioning is good, right? They feel secure and they're ready to try. But with him, we're working more on again, he's very involved neurologically. Okay, so that was just kind of general information. And now this is more of when you're actually watching the child eat. And during a clinical, this is more of a general slide. You can really kind of look at the oral and pharyngeal phase, but not completely with either. You can't really see everything in the oral phase like you could on a swallow study, and definitely not pharyngeal. We can kind of infer that maybe there is or suspect, like a lot in my documentation, if they've not had a swallow study yet, I'll say, I suspect pharyngeal dysphagia, right? And this is why, based on that coughing, choking, that wetness, wet vocal quality, increased pharyngeal congestion. Um, and in the oral phase, you can see a lot, you know, looking at like their labial seal, looking at their just cup and straw, and their mechanics and coordination and their bolus control. But even like oral transit and transfer, like commenting on if it's prolonged or not, I tend to stay away from that, because that's really, I need the swallow study for. And obviously you can look at chewing skills very well during a clinical, I will say. So that's good, but you can't really see everything. But that's okay. We just do our best here. And this is just kind of a, continued of what I was saying, and we're going to get into this a little bit more on the next slides, but really looking at like I can't see when they initiated that swallow, like was the bolus? Was it at the vallecula? Was it at the piriform sinuses? Is it delayed? I can't see that. Vocal quality, you can hear throat clearing. A lot of our older kids will kind of, after and do that. Um, and then the more obvious ones, like the coughing, choking, changes in facial expression, just their behavior looks a little different. We talked about chest congestion. You can kind of put your hand on their back and feel that. But again, this is all clinical observations, right? Okay, so if you want to take a picture of this, please go ahead and do that. This is a table we typically use in our documentation. So you can see at the top, like, you have whatever consistency you were doing. So the liquids, and then you move to your puree or whatever you're doing, and you look at anterior spillage, right? Do they have any spillage to their chin, their chest? We have kids that have a lot of that sometimes. Labial seal enclosure around the bowl of the spoon, the edge of the cup, the straw, bolus procurement. So I like to comment on, like, sometimes, like, is the caregiver really the one, helping get that liquid in their mouth, or is that child doing a pretty good job? Is it a combination of both? And really the coordination of that bolus procurement. Um, Obviously with liquids, you're not going to look at chewing, but if you were doing a solid, like, comment on their, what is their tongue doing, right? Like, are you seeing consistent tongue lateralization to move the bolus to the side, or is it more intermittent? Is it not coordinated? And then are you seeing vertical chewing? Are you seeing more of the diagonal rotary chewing or the circulatory rotary chewing? Again, oral transit, I tend to not comment on timeliness, but is it organized? This one's a little bit hard to see, I think, subjectively. It's hard. Oral residue is a little bit easier, right? After they're done swallowing, like, do they have a ton of like little pieces of solid left in their mouth just throughout the oral cavity? And then you're going to get into those clinical signs of aspiration or swallow dysfunction, coughing, choking, signs of respiratory distress. So like increased work of breathing. Did they any color changes, right? Like, we don't like to see that, but it happens. We've seen it, some of our little ones, especially more when they're bottle feeding, but it can happen. You'll see some color changes, vocal quality post swallow. So how does their I will have the child often, like, I'll ask them a question purposefully to get them to talk to me, and I want to listen for their vocal quality, or have them count with me, or I'll say, sing me your favorite verse of your song. We do stuff like that, just to get them to kind of engage. And then obviously, like we said, throat clearing, and then that increased pharyngeal congestion. So, wetness and increased congestion, sometimes that's a little hard to tease out or can kind of sound very similar. And then really important, I think, during these evaluations is what are the interventions you trialed? Because this is going to be, can you give something to the parents to start trying at home? I think that's really, caveat being though, dependent on the parent, right? And dependent on if you think they can do that properly, or do we need more education and time with them? So that's going to be different, I think, and you kind of have to feel that out with the parent. But like, for example, spoon feeding. Okay, did light downward pressure help with getting that tongue down? And did jaw support help with the stability aspect and help with that AP transfer? And help them be a little more coordinated and have less anterior spillage? Did placing the food on the side of the mouth laterally help elicit more of those tongue lateralizations, and really help with more vertical chewing versus the interior munching? So like things like that you're going to write. Pacing a child, was it single sips when you're doing the straw or cup? Did you need verbal and visual cues, right? To like, how much did you need to have them not just chug from that cup or that straw, right? So all those things, like, those are just some interventions we try. Volume they consumed, and like, and in the other comments I might write like any behavioral things I noticed. Sometimes just like if they didn't eat a lot, mom was like, mom or dad will be like, oh, but I did feed them prior to the evaluation. Just like little things there I'll put. And then this is basically kind of like in our assessment section of the actual documentation. This is just a smaller version, but if you want to take a picture of this too, I think this is a good one to just kind of, if you need something a little bit simpler, quick, this is really helpful as well. But again, goes through kind of the oral phase, and then some of those pharyngeal or overt clinical signs of aspiration on there. I tend to like this one better. Honestly, I think it's a little more comprehensive. But this is fine too. Okay. Again, so it's not just about looking at their skills, but looking at their behaviors, right? The sensory aspects. Gagging due to a texture. If you start with a smoother texture and you try to give them something with more texture, what stress signs are you seeing? Are they pulling away? Are they facial grimacing? Are they gagging? Are they vomiting? I just had a kid do that to me on Friday. Gagged and just vomited everything we just went up on the volume a little bit with some texture puree, and it was like, nope, okay, that's our stopping point. That's where we've kind of hit our ceiling with that in therapy. I'll see a lot of gagging and just like dry, like retching sometimes. And then again, just flat out refusal. Like, I am not touching that. I am not looking at that. I am not looking at you. You are not here. The food is not here. I want nothing to do with this. Or kids who just have really very limited reactions, just kind of stare at it. There's no motivation to eat, things like that. So really teasing out, what are you seeing? Is this a fear base? Is this kind of refusal? Is this a lack of interest? What is this? What are you specifically seeing? And then again, yeah, we have tons of little ones who just won't sit, right? They won't sit in a chair. They won't sit on mom's lap. Um, but you have to realize, is this typical for them? Is this just because they're here? I'm new. This is a new environment. Like, what is this? Crying, fussing, like getting, upset. And then, oh yeah, purposefully expelling liquid or food, or purposefully, like we call it, kind of like holding in their mouth things. That's important too, though, because that could be a sign of something else medical going on. I would refer to GI if they're pocketing food a lot, that might be a behavior that's a result of something medical. So always be thinking about that too. Again, why, not just the behaviors, but why could these potentially be happening? And is this child medically managed? Okay, so I think I kind of touched on this already, so I'm just going to kind of breeze through this a little bit. Again, we only get some information on the oral phase, like I was saying. You can't get everything. It does not give really anything on the pharyngeal swallow. We can infer, we look for those overt clinical signs, but you really need something more objective, right? Like a fees or a swallow study. And really, I would say video swallow study to be able to look during the swallow, right? At that pharyngeal swallow physiology. And then, like I just said, you can only suspect pharyngeal swallow impairment. That's okay to write, though. I think based on what you're seeing for your clinical, suspected pharyngeal phase dysphagia. And then obviously we can't detect silent aspiration. So I think and even though we can't see that, I personally think that kids will still sound, even with silent aspiration, this is just my own, like they'll sound wet, or sometimes you just can kind of just, you're like, I feel like this might be happening. And you'll hear that wetness a lot, but again, you can't say they're aspirating just based, like, definitively based on that. Okay. And then recommendation. So we kind of went through the evaluation, what you do before, during, and so this is kind of continuation of during and then after. So obviously, like I said, make those positional changes and see what can they do at home. Like if they don't have a chair, I have a lot of families that don't have access to high chairs and things, and what could we do to help with that? We're going to make recommendations regarding their oral intake considering their current skills. So like maybe they're an 18-month-old, but their skills are looking more like a 12-month-old. Okay, what texture should we modify so that they can be an efficient, safe eater and get their caloric intake and get all the nutrition they need, and also work on skills. You've got to meet them where, because sometimes parents are trying to give them a texture that they're just not ready for. And so they're not efficient, they're not safe, right? But they're just not ready for that quite yet. Compensatory strategies, I kind of touched on this with when I was talking in that table. So like, how did you help them chew? Did you place things laterally? Did you try putting some things, we have little mesh bags we use sometimes. Did you try a chewy tube just to see, things like that. Um, did you use a different cup? Did you help with pacing? Did you have to squeeze the straw bottle a little bit more, right? Like, what are we doing? What strategies could I maybe give parents to as well to start working on? Again, that's only if we think they're kind of ready for that. And then again, does this child need more consistent therapy? And do they need once a week? Can I see them once every other week and then once a month? And really talking about with the parents, like, this is the plan of care I'm seeing. And a lot of people can't come in every week, right? Like, I know we're in a medical center, parking's expensive. It's hard to get there for a lot of parents. Could we potentially do some telehealth visits, things like that? But really laying the groundwork for them is really, really important. So you get that participation from them to come back. And then obviously determine, do we need more of an objective study, like a swallow study or fees, and which one would be more appropriate for that child? I tend with my older ones to go for swallow studies a little bit more, but I think fees can work at times too. Just kind of depends. And then you determine if other referrals are warranted, right? So, does this child need a physical therapy evaluation, right? Based on what you were saying. Do they need to go to GI? Do we need dietitian involved? Do we need to get them to ENT, right? Things like that. So just kind of going through all of that. I'll go to the next one. Okay, now on to Natalie. I feel like.
Okay. So when we talk about our plan of care, what we're talking about is the long-term goals, the short-term goals, as well as the family goals. And this is something that's really important. And I know Lauren and I talked to families extensively about our goals have to align. So with our family goals, giving family, and I'll go into this a little bit in a couple slides, but really telling the family that together as the therapist, as the family, we have to come together, see eye to eye, because that's really when progress is made. Okay, so for our long-term goals, our bigger picture goals, these are ones that are mostly focused on patient safety during PO intake, as well as improvement in their feeding skills so that they can meet their nutritional and hydrational goals. Usually for us, we're setting a 6-month kind of time frame. That's what we keep in mind because that's what works for our facility and just the way that we practice, and also the thought that because we're at the medical center, we're trying to get more kids in. So always think about what works best for your facility and your setting. We thought it would be helpful to list a couple specific long-term goals. And I'll read them off to you. So that patient will improve oral motor feeding skills and swallow coordination to consume a least restrictive liquid viscosity and solid texture orally without overt signs of aspiration or pulmonary decline. So that would be one example. And the second being that the patient will orally consume the least restrictive liquid viscosity or solid texture safely and efficiently. And you can go into those specifics in your short-term goals. You'll see that shortly, without signs of aspiration and without pulmonary decline to support their adequate development and growth. So you see they're general, but they're allowing you to be more specific in your short-term goals. And that's next. So our short-term goals, it's really important because we try to hone in on very specific areas we want to target while always keeping in mind like the long-term goals. When we talk about specific, the reason why is because we want these goals to be attainable. There's no point in writing goals for our patients that are really general. So every time they come in, you're like, are they actually meeting goals? The more specific, the better. And to remind us of how to write these goals, we think of the acronym SMART. And what that stands for is specific, which means what specifically do you want to accomplish? How are you measuring, right? Is it measurable? How will you know if they've achieved the goal? Is it achievable? So whether or not the skills, you have the skills and resources to allow that child, to encourage that child to achieve the goals. Is it relevant? Does this short-term goal align with that long-term goal you have? And then timely, and how many sessions would you like for this patient to meet these goals? So think about, you want to set the patient, family, everybody up for success. The more you stick to this style of goal writing, I think the more successful you'll be as the clinician, as well as just big picture for patient care. Talking about family goals, we can go to the next slide.
Yeah. Oh, can I add one thing, Natalie?
Yeah.
Sorry.
Go ahead.
Sometimes I write my goals with this is just another way to look at it, percentages. So they will lateralize solid to molar table on 80% of opportunities, right?
Right.
Because sometimes if you put 20 times, or maybe not that one, if you put in, like if you put 4 out of 5 trials, you box yourself in, you have to get those, let's say 5 trials. And if you don't get them during the session, for some reason, maybe that, things happen, right? You can't take your data. So for me,
right,
I will do a percentage, because let's say I got I got less trials that day,
right,
but that's okay because I can do percentages. So just another way to think about that.
One more thing before we move on, Lauren, if we can go back with, like, for the first example, I just want to show you of how specific we start. So the patient will consume single sips of thin liquid via an age-appropriate drinking vessel. So you may have input like whatever vessel you're working on without demonstrating overt clinical signs of aspiration 10 times across 3 sessions. So you have the specific, measurable, achievable, relevant, timeliness. But if you see single sips, so your next goal may be, when advancing, consecutive sips. So it is specific enough where you can easily think of how you're going to advance and get to the long-term step when you take those baby steps in that direction. Okay, so family goals. Again, family goals and clinician goals have to align, but it's really important that I think it's part of being a good listener. As a clinician, you have to validate what the family wants, what they see for the future of their child. Sometimes, unfortunately, and it's sad when families come in and their goals are just not realistic or attainable. And so we have to have these tough conversations with our families and saying, you know what? Your kid is exclusively G-tube fed. They have this very complex medical history. Let's keep that in mind while also keeping in mind that they can progress. They can, move forward, but it may take longer to get to that big picture goal. So why don't we say, let's keep experiences positive, let's keep exposures frequent, but kind of getting them to see and meet you kind of halfway. So it's important that our goals align, and then also always considering the cultural considerations. So a lot of times families just want their kids to participate in meal times. They want their kids to, experience table foods and just bringing those foods to their mouths so that they can be a part of that, because we know that the social component in feeding is huge. Okay. So some of these examples of family goals may be to eat a least restrictive diet. So eat whatever is safest for them. For some of these kids, that might just be puree. Okay. Continue to explore the use of age appropriate drinking vessels. So maybe the kids were never successful with bottles, and the family's just like, I want them to try any kind of bottle that they want to bring to their mouth that they could potentially be successful with. And then a lot of times families are very aware of their child's history of aspiration and how overt these signs are to them at every feeding. And imagine the stress they feel. So they may say, I just want my kid to not cough and choke as much during mealtime. Okay, next slide.
Yeah. So I know we looked at the goals, we set some goals. So now you bring the child back in. So we just want to give an example of what a treatment session might look like, more from that habilitative perspective, right? And then Natalie will get into more rehabilitation as we go. So I think the biggest thing is creating a calm, safe environment for that child and that parent, and just remembering children learn through play. So your first few sessions are just building that rapport, and you, depending on this child's history, like I was saying, they can have pretty traumatic histories, or even if they haven't had, a prolonged hospital stay, just their feeding experiences at home can have previously and currently be very just negative. So you need to just try to get them to understand, I'm safe here, this is fun. Do some sort of therapeutic play activity. And again, I am trying to get them to just engage with me, sit in a chair or sit somewhere and not be super stressed, because we know fight or flight goes, as soon as that triggers, appetite literally is suppressed.
Yeah.
So just biologically, I need this child to be calm and kind of at their baseline, right? Because they're not going to want to eat and participate if they're not. So I tend to, I'll ask those families, hey, when are they typically eating? And I can kind of figure that out when I do the history, just their times of when that child is eating at home, so that we can bring them hungry to the session. Again, I think the take home here is medically managing these kids and making sure they are hungry and doing whatever we can to ensure that they are hungry and have that internal drive to eat. I have a lot of kids who have NG tubes and G tubes. So, hey, can we hold the 1 o'clock G tube feeding? So when they come, we're gonna do our oral trials. And so like parents are really a active participant, and they are on the same page as you. It's not just you telling them, like what to do. You're really a partnership. That's how I look at it. And I look at it as actually they have the most data points. They know their children the best. So they are your biggest help. And I know sometimes that takes time to foster those relationships and foster that trust, and it is their child. And I think, again, this doesn't just happen within a couple of sessions sometimes. Other times, and you know how that is, you click with certain parents a little bit more, or just depending on what they're going through in life, I think is a huge just factors too. and just what cognitively they're and emotionally what they have to offer, right? And just meeting them where they're at. Always, again, I won't get back on this soapbox, but proper seating position, adaptive seating, their high chair. For your older ones, can they go to the small table, but can they stay seated and not be getting up and running to the door the whole time? What postural supports do they need and things like that? And then again, I always review my short-term goals with my family so they know exactly what we are targeting. And if I'm doing more of a play-based approach, again, I say, well, children learn through play. I am quite literally using neuroplasticity. I go through all of this as a model of treatment, right? Positive feeding experiences, trying to shape their brain quite literally, those neural tracks, things like that, through positive experiences. And a lot of these kids have had really, really negative experiences. So again, this all takes time, but starting maybe with a more sensory play-based pre-feeding skills. Can they tolerate it to their fingers without retching, gagging, and vomiting? I had a little one who was like that. He could not even smell it, and we would start the retching, right? Then we move into more of our mechanics, spoon feeding, cup straw drinking skills, chewing skills. I am not opposed to using, and again, depending on who you talk to, they might say something different. I am okay with using a little bit of a reward system initially to get them to engage, and then I gradually fade it. Again, I am just trying to make a positive feeding environment and experience for this child so they will participate in therapy and literally change their brain. That's how I look at it. And really, you need to think about your time allotted to target each goal and how you're going to collect your data for that session. So, and then I think the most important part of the session, hands down, is that caregiver education, caregiver check-in, reviewing those goals and going through what is your plan for the next session. I don't think the point of therapy should be you only bring your child here and we only do things here, and the carryover has to be there. The carryover for parents to feel confident, know what they're doing, know specifically what we are targeting, and then be able to do it in their home environment, right? You might only see that kid once a month. You're not, these parents, again, they have to be, they're your co-pilot, right? So really taking that time to get into that caregiver education and say, what questions do you have? What doesn't make sense to you? What do you think you're doing well? What do you think that you just need more support on? And then for a lot of my parents too, it's once I figure out what type of learner they are they visual, verbal, like writing things down, the notes app in their phone, if they have if they have that capability, I have them write things down. Like they can look at you and say, uh-huh, 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 and then they get home, they have other children, life goes on, it's hard to remember sometimes. So just again, giving them that extra support that they're going to need and that they should need, honestly. They shouldn't, this isn't just come naturally to a lot of parents, and it shouldn't, again. So you're there to guide them, not just tell them what to do. And you want to teach them how to problem solve. You need to start to teach them what to do at home. So
Okay, so keeping in mind that we've gone over a little bit on time, and that we want to allow for questions after, I'm just going to go through the next couple of slides rather quickly. Feel free to take pictures of the graphs to come just to reference. And Lauren just talked about habilitation and treatment for that population. We see a lot of patients that come in for like rehab, but not as many. These kids we're working with families, with patients to get these kids back to how they were previously consuming food. So getting their skills back, working on getting their skills back, and then growing and improving and progressing those skills. And so the population we're talking about are brain injured kiddos, head and neck cancer, neurological disorders. And the goal is to improve the swallowing function through a combination of exercises, strategies, and modifications. I'm going to go a little bit into this in the next slide. If you see here with oral motor exercises, the purpose is really to strengthen and improve their coordination of the muscles involved in swallowing, including the tongue, lips, and jaw. None of the exercises we would do, tongue exercises, lip or jaw, would ever be in isolation. So can you go to the next slide, Lauren?
Yeah.
So the examples you see for on the far left of the tongue, lip, and jaw exercises, none of these would be we would never encourage the patients to do this in isolation. We'd want it to be done specifically in the context of feeding. So maybe with tongue exercises, we're encouraging families and patients to put the whatever material it is, a soft solid, on their molar table, and getting kids to move their tongue over to the left. With lip exercises, we're having them really seal their lips around the spoon. And then with jaw exercises, again, with chewing, working on those movements that are very appropriate. Thinking always, like Lauren was referring to, neuroplasticity, the specificity of the task, how important redundancy is, right? That practice of that very specific skill. With swallowing exercises in these kiddos, we have 4 examples of ones that we may encourage kids to do or our patients to do for very specific reasons. But with the greater purpose of improving the different phases of the swallow, including the oral and pharyngeal, really. Dietary modifications would be modifying what they're currently eating. So whatever it is that is working for them, that they are safest eating, liquids or solids, and then making modifications like thickening liquids. And we can do Lauren and I can do a whole talk on what we do for thickening liquids. And then modifying textures, making it softer, adding sauces to make it so that children are able to have maybe tougher to chew things that are more moist and manageable for them, cutting up the specific textures that may be hard for them into smaller portions. And then compensatory strategies that you see on the far right, really we use these to help us compensate for swallowing difficulties, right? So a chin tuck, a head turn, adapted seating or specialized feeding equipment. Okay.
Yeah.
Sorry, we're flying by this.
No, it's okay. And with the thickened liquids, Natalie, I'm just checking too.
Yeah.
We'll do, if we're going to recommend it though, we do a swallow study, right? Before we recommend it.
Yeah, absolutely. Yeah. We wouldn't, yeah.
Okay.
Okay. And so being at the medical center, we are super, super privileged to have some of these tools. And we by no means expect anyone to have these tools, but we're just showing what we have available. We have biofeedback tools, 2 in particular, and this is one. It's called the Synchrony Dysphagia Solutions by ACP. And the benefits of this would be to improve motivation and tolerance for therapy. And so it promotes functional outcomes and patient satisfaction and overall improvement to their quality of life. So within the context of this game, what's really neat is that we there's like attachment of these like little stickers. So it's electrical activity that is being measured. This is not delivering electrical impulses to the muscle. It is measuring the muscle activity. So when the patient is, for example, if you see that little kangaroo, they see this kangaroo, they swallow, the kangaroo jumps. So there's their biofeedback. I see that when I do something, this happens. If I swallow harder and stronger and in a more effortful manner, the kangaroo jumps even higher. So we have the real privilege of having something like this to help our kiddos. Of course, ones that are able to follow directions and cognitively appropriate for this kind of activity. The last one being the IOPE, and this measures tongue strength and endurance as well as lip strength. You see the kit that we see at the top. It's nice, it's portable, it's handheld. It comes with these little bulbs. And so they're air filled, and the benefits are being able to objectively kind of document what the deficits are and how to justify this treatment. Diagnostically, it's differentiating between muscle weakness and other problems of motor control potentially. Again, the neat part is it's providing biofeedback in these numbers. For example, these kids may put the bulb in their mouth, squeeze really tight against it, their tongue up against the palate, and see these numbers pop up on this device. And that can be motivating for a lot of our patients by showing this like progress.
Okay. So I think we're pretty much done then, because we went through habilitative, rehabilitative, and again, I just kind of put some other texts that are really great. I think there's just so much information that we can't get through, in an hour and a half. So these pre-feeding skills and pediatric feeding disorders, I think if you buy 2 things, those 2 things would be great. And then for those older kids or the more rehab rehabilitation perspective, this Clinical Management in Adults and Children by Michael Crary is very, very good. So if you want to take a picture of this too, I always say that, but this, I really like these because they go through evaluation treatment. They have templates in these that you can actually use for your evaluations. They're very, very, very good. So I'm just going to keep that up on the screen there. But we are done. So we can open this up for questions and comments. Yeah. I think we did pretty good here. What time?
I think so too. We covered a lot. Huh?
Yeah.
Hi, Lauren and Natalie. Thank you
Hi.
so much for the elaborate, presentation about the feeding and swallowing issues. And sorry for the little delay in
It's
starting
okay.
the program because there was the confusion about the timing. Last time the 9 o'clock in Houston was 8:30 here, 8:30 in the evening here. So this time it's little early it seems. So that was the confusion. So anyway, still we had some 50 plus participants. So that's
Great.
wonderful news. So everybody is interested in knowing from you. Um, so one question from me is very practical problems what we face is some of the times when the child is either tube fed or G tube or NG fed. Just for the sake of improving nutrition, if there is no structural abnormality, and just because the child is failure to thrive, we start on the tube feeding. So,
Okay.
is there any criteria? When would you restart oral feeding? I'm done with the nutrition part. The child is good, so now I'm going to restart the oral feeding. Is there any criteria you follow to restart the oral feeding from the G tube? I'm done with this.
Yes.
Yeah, something like that. You have
Right.
anything of
I
that
think
kind?
we work really closely with our dietitian, and there's really not a
Specific time
specific
frame. Yeah.
time sense. However, I will say, depending on different institutions, some will say like they need to be doing like 80% by mouth in order to get the NG tube out, or it's not 100% of feeds by mouth in order to get the, NG or G tube out. But I think it just is really looking at that child's how they're gaining weight and their nutrition and everything. I don't know if it's kind
Yeah.
of answering the question. And then even if a lot of our kids who have the NG or G tube, we're still working on oral feedings at the same time.
Right.
So we're doing both. Like we're never kind of just saying we're going to do everything through the NG or G. We these kids are dual feeding system kiddos.
Yeah.
So and we're working closely with the dietitian with that. I hope that kind of
and also keeping in mind there, like, what a great question. And I think always thinking, what are they safest to consume? So, if nutritionally they're not having their needs met and the NG or G tube is there, but we know that they're safe to consume other things, after a swallow study or whatever instrumental we have, that information is helpful. And always continuing with the PO feeds in addition, to that supplementation that they're receiving so that they're not losing out on the
and
skills.
exactly, Natalie. And I think like you were talking about, if it's not a structural issue or this is more for failure to thrive, like you were talking about. We're working with dietitian to look at too, like, can we start cutting some of what they're getting through the tube so that we can encourage those hunger cues and encourage them to be doing more by mouth? Like, and that's where that's a great question. Like, I don't know that. How much are they comfortable cutting? If they are failure to thrive, we're trying to get them to gain weight, but that usually comes a little bit down the road. I think the primary focus at first I get is getting them to gain weight, be healthy, get the nutrition. But really, we work very closely with our dietitians, I will say.
We do.
Yeah.
Thank you. Is there any other question from the participants?
I had a question. Does anyone have research or anything based on like what I was kind of talking about, the oral motor skill progression, more like typical feeding milestones for children you're seeing in India versus like a more westernized approach? Just because I do think, again, your kids are doing different things earlier than ours sometimes. So it's just interesting for me.
Yeah, is there anyone, any
I don't know if that's even
SLPs who can answer
a good
the
research
question?
opportunity.
Yeah,
Or otherwise,
there's
we will start one. We will have
yes.
a start a
Yeah, I
study
think
based
that's
on this.
really important.
Yeah.
But
There may
that's
be some
just,
questions in the message, like with the messages, because I keep seeing the little
Yeah.
oh
Yeah.
something
yes.
pop up.
The chatting as a guest. Got it.
Uh, oh, I see
Somebody's
this one.
told that it's very useful. One of the
One
clients are
one
recently.
person one person brought up that they had a child who had HIE and had an issue that they
Mm,
couldn't manage their own secretions. Can you talk a little bit about secretion management?
Yes, yes. So that can be very, very challenging. And also just getting parents to understand that their child won't be successful doing anything until they are able to manage their own secretions, and also getting them to understand why. Why is your child not able to manage their secretions? Are they not sensing them? What can we do in therapy to get them to be more successful in doing that? So making sure their head and neck are in a neutral position. If they're a lot of these kids, like the HIE, neurological components where they're going to need all the support to keep their head and neck up anyways. They're going to need some suctioning. So really working on getting parents to understand and caregivers to understand the importance of just swallowing and the repetition of just swallowing. So I spend some of my sessions with this population, most of my session, really doing like oral care and oral hygiene, because we know that these kiddos are more prone to aspirating secretions, which are bacteria filled. So oral hygiene to start, really reinforcing the importance of that a couple times a day, suctioning as needed, and then providing kind of tactile or kind of something in their mouth so that they're wanting to swallow. Now, you can go crazy
yeah,
online, finding
yeah.
things that you can put in their mouth, but really anything, whether it's like a sponge or whatever it is to elicit a swallow.
I think more non-nutritive and things that
Yeah.
are applicable to that. So a 3-month-old, what might they be doing? Even if you want to give them positive, non-nutritive stimulation. I mean,
Yes.
putting anything in their mouth, a blanket,
Pacifier.
anything.
Yeah.
Just exactly keeping them. You can do pacifier dips, right? And I think the point with this is, again, like Natalie's saying, trying to keep them swallowing. It also kind of really does depend on how bad their oral secretion management is.
Mhm.
It mild, moderate, severe? If it's, and that's tough. And I also think talking with parents, hey, you know, once we can move on, once they get a little older, maybe start some, the dry spoon in their mouth, right? Just getting that stimulation, and then start small tastes of purees, like letting them know that we will be able to progress, but right now we've just got to
Right.
work on
Right.
this, like giving them a plan kind of. It's very hard though, because
Go hard.
and these children's, especially with the HIE, which is going to be turned into probably like CP, and they're going to have long-standing issues. So just kind of laying the groundwork for that as well. Someone else wrote, can I look at this? Challenging thing is to differentiate between either oral sensory issue or behavior.
Yeah.
Yeah, and they kind of go together because they go together. You're right.
Yeah.
Those sensory issues then present as behaviors, right? Like, because they're having issues with that, then you start to see all these behaviors. So, I think, again, really teasing out what specifically are they having issues with, and how much do I need to back this up? Just
Mhm.
just maybe you don't even start in their mouth yet.
Right.
You know what I mean?
And
Yeah,
and talking
sorry,
about what you go
go
ahead.
ahead, Nat. I was just going to add that I think one thing that Natalie and Lauren are really good at, and our speech team, is also making sure if we can get them access to PT and OT also.
Yes.
And
Yes.
I was going to bring that up with the HIE kid also. We see as these kids get, if they can get strength elsewhere, that usually
Mhm.
also helps with their strength with swallowing.
Yes.
And so working in tandem with those other therapies can be very helpful.
Absolutely. Are there any other questions?
It says, what are other early feeding skill tool assessments? I like to go on Feeding Flock. I don't know if you know that one. That's a really good website. Or there's like the PD Eat and the Neo Eat, like all those types of things. The thing are, those are more parent-based, caregiver-based questionnaires. I tend to look at skill
Right.
just objectively more. I don't necessarily use like you can use caregiver tools. Those are fine with getting information. But they're more criterion referenced, right? Those types of
Yep.
things. Natalie, any other things you're using?
No.
Yeah.
Yeah, it's more skill-based for me too.
Yeah. But the PD's a good one, I feel like. And again, there are some tables and other things in some of these texts you can use too.
It
For
might be
childhood.
interesting to look at some of those existing questionnaires and seeing if we can validate it in
Uh-huh.
different, like in your population.
Yeah.
And I'm so sorry, I'm not familiar with, I know the questionnaires, but I don't know all the elements of them. But I think there are probably some things that are more, the skills are a little different than, that can
Absolutely.
vary
You're right.
per by culture. So that might be
Yes.
something that you can adapt to your population.
Absolutely. I think you're right. There's more like they look at behaviors versus skill versus you're exactly right, Dr. Rowell.
Yep.
Oh, this is
Yep.
interesting. Do you think there's
I
a
see that.
research gap for SLP based tools? 100%.
Yes.
You do not have enough research there. I think so much more needs to be done.
Yeah.
But so yes, yes, and yes.
So there's a question on drooling management, and the question is thermal stimulation useful, and what can we do to control? I think it's useful in eliciting a swallow and just getting our kiddos to clear the secretions they have in their mouth. But how useful can it be throughout the day? Usually caregivers aren't going to be doing that all day. However, if it's done, for example, in therapy, lots of repetitions, it can be helpful for the general swallow. Why not try? A lot of times with our kiddos who have pretty intense drooling issues, they're going to ENT to help them manage their secretions.
Yes.
Do you,
And we have
do you guys do a lot of Botox for these drooling kids? Is there
Yeah, we
any
do.
stringent criteria for that? Or maybe
Yeah.
Nicola can
Yeah.
answer this question.
Yeah, I don't know that we have an exact amount as to how significant it needs to be, but certainly for our kids who have swallowing issues, difficulty managing their secretions, the parents are complaining that they're soaking through multiple bibs a day, things like that. Depending on the age, we may start with something like anticholinergic medication, and if they really don't do well with that, then we may go to Botox and even go all the way up to tying off salivary ducts or excising glands. Now, I love Dr. Lambert gives really nice talk. One of our partners, he really manages a lot of kids with sialorrhea, and he talks about that a lot of these kids need multimodal therapy. So it might not be enough, even if you do the Botox or even if you do, tying off a gland, you may still need to do the anticholinergic because they have such a hard time with managing secretions. Typically, it's not overproduction of secretions. We know it's just poor management. So, for some kids, it might be a temporizing measure as they get stronger, but for other kids, it may actually be a long-term thing that to even give them a shot from a respiratory perspective or a swallowing perspective, that we have to continue that management. And we usually will do those Botox, we'll do the injections under ultrasound guidance.
Thank you.
Oh.
I think we are done for the day.
Yeah.
So thank you so much, Lauren and Natalie.
You're
It was
welcome.
wonderful. It was a wonderful
Very
session.
welcome. Thank you all for joining us.
Thank you so much. Thank you.
Yep.
Thanks,
See you
Nicola.
at the next one.
Thank you all.
Bye.
Bye-bye.
Good job.